Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole, here with Tanner, and today we're going to do our part 2 episode talking about emergence from anesthesia. And so if you haven't listened to part 1, I encourage you to go back and do so. We basically went through and talked about what is the overview of emergence. And it's this idea that I think we described it as it's something you can teach somebody off the street how to put a patient to sleep in about a week or two. It's a matter of how do you wake somebody up and emerge them from anesthesia and do it consistently uh, from a patient safety standpoint, but also a smoothness standpoint, a pain control standpoint. How do you consistently get that outcome by doing it a variety of ways? Sometimes you have to do a deep emergence. Sometimes you do an awake emergence. Sometimes you do a patient where you don't want them coughing based on the procedure that they had. Sometimes you have to add in different medications because you have a patient that's on chronic opioids. How do you get a patient in all of these situations to have the same outcome when you get to PACU? And that's to drop a patient off that's stable from their vital standpoint, breathing on their own, but they're also comfortable from a pain standpoint. And that's the part that takes years to master, really, as you go through clinical for several years. And then even as you go into practice as a CRNA, there's so many different nuances and different tricks and tips that you have that goes into how do you emerge a patient. And so we spent a lot of time talking about the different ways that you can do this. And to be honest, Tanner and I disagreed on a lot of this because we each have our own ways that we've acquired that we like to do. And because of that, it's not saying that one of our ways are wrong necessarily. It's just simply, it goes to show there are so many different ways to do this, so many ways to wake up a patient. And for that reason, we wanted to continue the discussion in the part 2 today as we talk about what are some of the alternative methods that you can use to emerge a patient.
I think it's funny, over the last 2 weeks, we had a friend group going through CRNA school, and we have not talked in probably 8 months, but every once in a while we'll just start up a conversation again. And this is like the core group that we would always study together. And it's just been really funny to catch up with them because what we've been talking about is different situations in the OR and specifically all surrounding emergence. And you thought Cole and I had difference of opinions. You had 2 more people into the group, and none of us think alike. We all trained same place, same school, all work in fairly similar work settings. And yet between the 4 of us, again, it could not be more different. And so, like we've said multiple times on this recording, take everything we say with a grain of salt. If you're in school, you're likely going to have somebody that has an opinion on how you're going to emerge that patient. If you're out of school, hopefully this is just some more information of how different people do it. Or I always think that's fun when you go into a room giving a break and you see somebody else's anesthetic, because we get so locked into our own room and our own ways of doing things a lot of times we don't get to have the exposure. So hopefully this is helpful.
But to your point, Tanner, that's why I think that the hardest part of anesthesia school for me was not actually learning the anesthesia content. It was dealing with all the different preceptors and the different ways of doing things, because there is 1,000 different ways to do anesthesia. And that just goes to show, as you mentioned, all 4 of us in that group went to the same school, have the same preceptors, the same clinical sites, and we all 4 have come out to have vastly different ways in which we like to wake up patients. And that just goes to show, again, that there's so many ways to do it. And the hard part for me was what you did yesterday in school, you may get yelled at for doing today in the OR because that preceptor likes to do it a completely different way. And for one, that just shows as preceptors that we need to be cognizant of the fact that so many people often think that their way is the highway in anesthesia because that they see that you have good results. But when you look at PACU, more times than not, the majority of the patients all have the same results. They're all lying there comfortable. They're all, for the most part, pain-free if you're all practicing well. And I guarantee you, everybody had a vastly different way of arriving there. So as preceptors, we need to understand that we should not yell at our students coming through, the residents coming through, because they're doing something a little bit differently than the way that we do. At the same time, as a resident, we need to understand that it's okay to learn a different way of doing things and be open to that. And you're going to add more things to your tool belt that you may use and you may not use in different situations.
I had a case yesterday that I had the patient intubated. They were lateral, young male, redhead, just looked like he played NFL football. Just like if this guy woke up and was ready to tussle, I was exiting the room. I mean, there's no way that like I'm going to take this guy on. And it was a fast turnover room. You're trying to move things along, and I was talking to the team, and they were like, "So, is this going to be an exciting wake up?" And I was like, "No, I think I got him in a good spot, and I think it'll be okay." And ended up going well. But the point I'm trying to make with that is how I woke him up is not how I usually wake other people up. So again, this whole episode is like, here's what we like to do. But then patients come in, they have different comorbidities, they have different things that you need to account for, different surgical procedures. And it's such a fluid thing. And we're going to stop saying that over and over and actually get to the topic today. But it is just trying to reiterate and help you feel, I guess, a little more comfortable. If you feel chaotic in this situation, that's okay and that's normal. And there's a lot of factors that are going in to making these decisions of how you're going to wake these patients up. So let's get back to it. Let's talk about pain control, because we talked last time about actually how you're going to get them to the spot where they're reversed and they're spontaneously breathing, and how we're going to wean down our gas, or you're not going to wean down your gas, or whatever you're going to do for your emergence technique. But one of the reasons that we like to get them back breathing quickly is because you can assess for the pain level of the patient. You can see this multiple different ways as well. You can look at heart rate, you can look at blood pressure. But one of the best indicators for understanding how comfortable a patient is going to be looking at their respirations. So when we have them back spontaneously breathing, you can see, okay, this patient breathing 30 times a minute. At this point, if the patient is fully reversed, and I'm not concerned that maybe they're just weak and they're not able to take good volumes, so now they're compensating with a higher respiratory rate to maintain their minute ventilation, then I have a clear picture that this is probably pain related. So at this point, I can start working in some pain control and trying to make sure that they are comfortable when they wake up. If you pull a tube on a patient who's breathing 30 times a minute, I don't know if you've ever had this experience, Cole, but obviously they look completely sedated because they're under general anesthesia. But if they're breathing that quickly, and as soon as they wake up, they are going to be just coming out of the bed, rolling, just like they're already ramped up. And then when you immerse them fully, you can get a really good picture when they're breathing spontaneously of how they're going to look when they're fully awake. If you have them breathing, 8 to 12 breaths per minute, when you take out the tube on those patients, a lot of times you'll just see them just laying there very comfortable. You can tell that they're going to be calm before you actually extubate or take the LMA out. So it's a really good indicator of how you're going to work in your substances to help with pain. This now becomes a decision of, with different patient comorbidities, is this something where I'm willing to give a long-acting medication? Does the case require it? So I could be giving in some Dilaudid, some morphine, or is this something that I think is just acute and really, or am I worried about their respiratory status and I want to give something that's just more short acting, and so I'd give a little fentanyl here at the end. Something that I would encourage you to do is, somebody did this for me when I was in school and it was really helpful, is take whatever time. So let's say we're in the OR, it's 12:30. I'm getting ready to extubate the patient. Literally draw a timeline of, it's 12:30 now. They're going to be in PACU by 12:40 or whatever. 1 o'clock, they're still in PACU. They're going to be in phase 2 by 1:30. They're going to be heading home by 2, whatever that timeline looks like. And then draw out the arc of your medications. So fentanyl, I'm going to have, coverage for about an hour. For Dilaudid, it's going to be much longer than that. So you're actually drawing out the arc of your medications, and then take into account what kind of procedure is this. Is this going to be something that's very painful, that they need longer coverage? It's helpful because then you can look at, am I managing this patient's pain, or am I just getting them through the procedure and then handing that off to somebody in PACU to then manage their pain when they get to recovery? It's going to help a lot with the calls you're going to get from the PACU nurses with the different patients that are still in pain or need something additional. But it's just helpful for you to visually see, okay, I'm the pain expert here. How am I going to take care of this patient's pain not just for the 10 minutes of getting them to PACU and giving a report, but actually as they go through phase 2 and as they're headed home. So this is the point where you get to make those clinical decisions about what does the patient need, what does the procedure need, and then you can start identifying what kind of medications you want to give. Precedex is also nice here if you have a patient that you're concerned that Emergence is going to be, a little more amplified. Maybe they were super nervous coming back. Maybe they were nervous about waking up in the OR. Or what I really like to do is, say you're in cath lab and they're needing to lay flat for several hours anyways. This is a nice time to work in some Precedex as well, because you can get them nice and smoothly transitioned over to recovery. And again, if they're going to have a long recovery time when they need to lay flat anyways, it's terrible to come out of a procedure and then need to just lay flat still. So if you can give them a little more sedation and pain control with Precedex, it's a really nice adjunct to use there.
Yeah, I love Precedex. That was something where I feel like, correct me if I'm wrong, but I feel like we didn't have a lot of preceptors that used a ton of Precedex when we were in school. Maybe towards the end we started to, but it's something that as I got into practice on my own, I truly discovered the magic and the wonders of using Precedex at the end.
It was the one time I got kicked out of a room was for drawing up Precedex. Yeah. Did I not tell you this story?
No.
All right. Fast forward a minute if you are not interested in hearing this story, but no, I was literally doing like a lap chole, and that morning I had drawn up Precedex, and the preceptor walked in the room, and I was like, "Hey, good morning, my name's Tanner," and she walked by me and walked over to my setup and then picked up the syringe of Precedex, and she's like, "You'll never draw this up again in my room. Actually, you can find a new room for today." And I was like, "Whoa, okay." So I literally was like, I was so nervous because I'm still training and learning, and I was like, did I miss something? Like, is there something specific about this patient that this Precedex would have been like horrible for the patient? And I was talking to the clinical coordinator, and they're like, no, you shouldn't have ever been in that room. That person does not like to have students, and will find any excuse not to have them in there. But yeah, Precedex was got me booted out of the rooms. I'll always remember that.
See, that's my other point too. Like, this is not just for those that are going through school to realize there's different ways, but it's a good reminder for us that have been out of school. And I mean, I'd like to think that you and I are just really fresh out of school, but it's approaching 5 years now already. But it's a reminder for us that there are so many other ways of doing things, and we get tunnel vision sometimes, and we get locked into the way that we typically do it, that we're hesitant to try something new because we don't want to have a bad outcome. That doesn't mean there is not a potentially better way to do it. And often,
and it takes some time too. Like, you have to, it's not going to be perfect the first time you try a new technique, but don't just burn that bridge that the first time you're like, you give 4 of Precedex, 8 of Precedex, and it takes longer to wake up. Don't just say like, well, that's like, throw the baby out with the bathwater. You're like, okay, well, I just need to, adjust my technique a little bit. It's not that the whole plan was wrong.
I remember in school, I had a preceptor that's like, hey, I've been wanting to try Precedex. Let's do it. And we gave 20 mics of Precedex to this. I can't remember the case, but it was a normal, healthy adult patient, normal body habitus. But the patient was like snowed in recovery for like 3 hours. And everybody was blaming the Precedex as the reason for that. And so she was so hesitant to do it again. But like, I give 20 mics of Precedex to so many of my patients, and I don't have that same response. And that was just like kind of it probably didn't help the patient being snowed in PACU for 3 hours, but that was not the only culprit, I would think, in that case. And if you only took that one situation, you'd be hesitant to try it moving forward. But moving on though, as Tanner said, you want to get the patient in that good pain control spot. So the last piece here we want to talk about is your final emergent points, or the final things that you want to do before you actually extubate the patient. So as Tanner said,
one thing I want to just go back to, I was just reading through my notes on this. There are times that you need to be very critical. You need to be thinking very critically about the patient in terms of, if you're very concerned about their ability to fly after extubation, there may be times when they are not breathing that 8 to 12 perfect picture. And you kind of live with the evil, of knowing the patient might have a little discomfort when they wake up, but knowing that they're going to be safe in terms of maintaining their own airway. And then you can start working in some medications after they're fully awake. So I don't want to say that like, this is a hard, fast rule. There are certain situations, maybe they have, a lot of lung disease, or maybe they're very elderly and have had a very difficult time waking up from anesthesia in the past. There are times when you will make a judgment call of, is it going to be more appropriate to make sure they're just, so perfectly comfortable, or is it more important that we safely get them extubated and then we could start working in some medication? So even with that point that I was making, I wanted to just address that too, that it's there are times when, again, with everything you need to use your judgment, but there are times when it would be appropriate as well to safely get them awake, extubated, over to PACU, and then start managing pain. And again, take into account what kind of surgery it is and what kind of pain they're going to be feeling. You don't want them waking up with an open belly and just, in terrible pain. That would be a nightmare. But there's some judgment involved there. All right, sorry, floor is yours.
Absolutely. So now that we've teed up the patient to have that final emergence piece and that extubation piece. So at this point, you have the patient hopefully in a good pain control standpoint. They're back breathing spontaneously. Depending on if you're doing an awake or a deep extubation, you're going to be weaning your volatile gas to the appropriate amount that you want. You reverse the patient fully. You're all teed up, everything that we talked about in the first part of this two-part series. So now, how do you know when your patient is ready to be extubated? And from a normal sense of when I talk about this is referring to an awake extubation. We'll talk about deep extubation in more detail here in a little bit. But for an awake extubation, again, you're trying to wean off all of your anesthetic gas, wake the patient up, and then emerge the patient from anesthesia. And so your attention then is now going to be directed to, when do I know is the right time to actually extubate a patient? When is it the most appropriate time? And this is when it becomes crucial, because if you wake up the patient and you extubate them as they're still emerging, and we call this stage 2, as they're going through the transition between being under anesthesia to being awake. And if you were to remove the tracheal tube at that exact moment, they're at a very high risk of having a laryngospasm. Their airway reflexes are very heightened. And as you manipulate the airway, when you remove that tube, they can spasm from their larynx. And in that case, then you're going to have a difficult situation that we'll talk about in just a moment of how do you handle that. And so we want to avoid removing the tube at all costs or manipulating the airway at all costs during this stage 2 aspect. So some of the things that we can do in order to have like this criteria for when is it appropriate to extubate a patient if you're trying to do an awake extubation. Well, the first and foremost, which is obvious, you want them fully reversed. You want your trend of 4 showing a 4 out of 4. You're not going to try to extubate a patient when they're still showing 2 of 4. So you want to make sure they're fully reversed. Again, you want to make sure they're breathing spontaneously. And the key here is you want no to minimal pressure support. And so I was talking to one CRNA the other day. He was like, "Oh yeah, I have people on pressure support ventilation. I just kind of extubate from there. I've never had an issue." But really what we need to be focusing on is they need to be able to breathe spontaneously without pressure support. Unless they're potentially somebody that requires that when they sleep, they require like CPAP, et cetera. But for most of our patients, you're going to want them breathing spontaneously without that support. Now, and what I mean by this is you want their tidal volume to really be at least 5 mils per kilogram. So if you have a patient that is 70 kilograms, you're going to want them to be taking tidal volume breaths at least at 350 cc range here, preferably higher than that. But we got to keep in mind that they're breathing through a straw. So depending on how narrow of a tube you're using, and depending on how many secretions they have, and if you completely suctioned out the secretions that potentially would be in the endotracheal tube, that's going to limit the actual tidal volume that they're able to bring in. So do keep that in mind, that while we want them to have this certain tidal volume, you have to judge the whole situation and say, okay, they're breathing through a straw. Do I have the feeling here that they're actually pulling more than that? And I can tell they're pulling more than that, but I'm not able to see that volume. But again, you want that number relatively 5 mils per kilo or above. Again, according to the book, you want them to obey commands such as opening their eyes. You want them to squeeze hands, the ability to lift their head off the table for several seconds, etc. That is all according to the book from an extubating criteria standpoint. Now, in reality, patients often are going to wake up, they're confused or somewhat combative. If we're giving them Precedex, they're not going to fully be awake from that standpoint. It depends on what all you're bringing in at this point. So how do you logistically analyze the patient and make sure that they're ready. Whereas you don't want to wait too long until they're fully following all these commands. And now you've kind of passed that happy medium of when you should extubate a patient. And now they're coughing, they're gagging, their blood pressure is raising, and there's this smoothness to it. And so how do you know when is that appropriate time? And Tanner, I don't know if you have good tips and tricks on when you'd like to do this, unless you mainly, we're probably gonna disagree here. Tanner probably mainly does deep extubations instead of awake, and then maybe I'll fill in. But really, from my standpoint, I want that patient to just get through stage 2, and I want to pull that tube when I know that I'm removed from that risk of having a laryngospasm, meaning I check their eyes. I'll pull back their eyelids and see, are their eyes midline and facing forward? If they're not, that's a telltale sign that you're in stage 2. I try to get my expiratory volatile anesthetic gas. Again, I use SIVO almost always. I want that around the 0.2 range. Where I've kind of gotten through hopefully that stage 2, but they're not fully awake yet. I want to make sure they're pulling those good tidal volumes. But again, I'll ask them to open their eyes, and usually if you give Precedex, this is great because they're not going to be doing much other movement, but then you say their name and their eyes start to open up and look at you. And that's like my telltale sign I pull the tube out at that point. I always will suction as I go to remove the tube, do a little bit of positive pressure, make sure the oropharynx is suctioned out, because again, the airway reflexes are kind of heightened and you don't want any of the secretions to drop into the airway and then cause coughing, spasming, etc.
Yeah, we're gonna deviate a little bit from, this is not medical advice. This is just like what you would typically see in practice. And so if your preceptor is asking you textbook definitions, you need to have them following commands. Train of 4 is 404. They're pulling 5 mils per kilo on their tidal volumes. All those things are great. In reality, a lot of times what you'll see, instead of having a patient that is there coughing and not breathing adequately because they're irritated from the tube, now you're seeing, not great tidal volumes, and it's not very pleasant for the patient. A lot of times you'll see kind of a mixture of these techniques. We need to make sure they're strong enough to pull volumes. So lifting the head off the pillow is a telltale sign. If they're able to hold their head off the pillow, that is going to be a great indicator that they are strong enough to be extubated, along with seeing regular tidal volumes and good tidal volumes. I don't typically have them following commands when I pull the tube. Typically when they're following commands, they're going to be awake enough where they're irritated by the tube. They're going to be coughing, and it can be a little bit of a mess. I will say, if I have a patient that I'm nervous is not going to fly, maybe they are obese and have difficulty with breathing, lying flat. With those patients, again, I'm going to have them sitting all the way up if possible when I'm extubating them anyways. But a lot of times these patients, there are some indications where you're going to want to have them like wide awake. Most of the time, if they're able to lift their head off the bed, and for me, what I do is I slowly deflate my endotracheal cuff. If they don't have any kind of response from that and they're breathing well, then the tube's coming out of there. If I do that,
We actually agree on that fact.
oh my goodness, yeah. If I start to pull that tube, and I'm not taking the tube out when I'm doing that, obviously, but if I deflate that cuff, and that's super irritating for them, and you can tell that they're not quite with it, and they're starting to have a reaction to that, then I don't have them in the sweet spot with Precedex and narcotics and all that kind of stuff where they're going to be comfortable with that tube coming out, and there's risk there for having laryngospasm. The other thing I'll do when I'm extubating these patients, the first step in difficult airway management is going to be positive pressure to the vocal cords. And so these patients typically will have an oral airway in already. I like to do that at the end simply because I don't want these patients to be biting down on the endotracheal tube. Then you have risk for negative pressure pulmonary edema. And so if I place that oral airway and I take the tube out, I have my APL turned up a little bit and I go right onto the face with the mask. I'm not giving them a ton of pressure. I'm just giving enough pressure where if those cords were trying to have some sort of spasm and trying to close, I'm already doing the first step in the difficult airway algorithm, putting positive pressure there right to the cords. I've got an oral airway in, so all the air is going directly there to the cords, and it just kind of keeps them open. Sometimes you'll see a little kind of breath hold, and then you'll see them just relax and start taking normal breaths again. So again, this is not, we're not getting this from any textbook, and this is not medical advice. This is just typically what you'll be seeing in practice that makes it a little smoother, and that each of your patients aren't, flying off the bed before you start extubating them.
So speaking of negative pressure pulmonary edema, do you know the population that's the highest at risk for receiving this, or for not receiving, but getting this? And it's often athletic males that are like the 20 to 40 range. And so really, like, Tanner and I are prime candidates to having this. So if you ever take care of one of us, make sure you avoid this at all costs.
I mean, we're males. I don't know that we're athletic, but we're males.
Yeah, we try to be athletic.
We're
So-
dads. Yeah.
Father figures is what I like to call it, right?
Yeah, right. I've got the father figure, that's for sure.
So but basically, whenever I have a patient, I mean, really all patients, but especially this population, I'm really concerned about the negative pressure pulmonary edema. And so that really plays into, how alert do I want this patient before I pull that tube? Do I want to make sure I have all the other medications on board to make this a smooth transition for the patient? And that's definitely where the oral airway helps. So they can't actually bite on the tube, because the problem is when they bite down on the tube, and I've had this happen once or twice when I was in school, and it definitely scarred me moving forward, that I did not want to have this happen in my practice, where the patient completely bit down on the ET tube. You can't get ventilation. There's no movement of air. They're clamped down. You at this point can't get the oral airway in because you can't open their jaw enough to do it. We had to give them a huge slug of propofol, and one patient that worked. Another patient, we almost had to reparalyze to get them to finally relax. But it's just scary. And at that point, now you start suctioning out pink frothy sputum from their lungs, and it's just not a good situation. So that
can happen in one breath with a very strong patient, and it, like, in a totally clamped down tube, that can happen in one breath. So it's not something that, like, you have time to address. That happens very quickly.
Right. And so that's something where, as Tanner said, get that oral airway in sooner than later. I know some people through school that they have me keep it in for the majority of the case. I don't love that. You're just asking for there to be a pressure sore. You're just asking for that when you have something that doesn't need to be in the mouth there for several hours. I could see if it's a quick 15-minute case and you just want it in, and but other than that, I typically, the moment I start my extubation process, or excuse me, my emergent process, I'll put that oral airway in right away. Okay, so now you get the patient extubated. And again, I want to tell you, like, this is the method I use every time, but it changes so much on exactly when I pull the tube, etc. So it's just hard to go into that, especially when we're not in the OR going over this together and we're just doing this through a podcast format. But once you get the patient extubated, I typically keep that oral airway in until the patient starts to really open their mouth and kind of gag on it. And then I'll just say, hey, say ah, and I'll take that out. But for most patients, I typically have them pretty calm at this point, especially if I do a Precedex extubation where I'm have Precedex involved towards the end. I typically will do about 12 to 16 mics in the last 15 minutes before we wake up the patient. And so typically they'll just be nice and comfortable, and I'll just put the oxygen over top the oral airway so they're breathing through that. Otherwise, you just put nasal cannula in. Sometimes we'll put a non-rebreather mask on. Each person has their own preference. And you want to, again, make sure that they are having complete ventilation, that CO2 is leaving the mouth. And so I should back up a second. Right after I do extubate, I will put the mask circuit from the anesthesia machine on, make sure I'm getting in tidal. And oftentimes, they will need a little bit of an assistance, maybe a little bit of a chin lift, a jaw lift, just to make sure that they're fully ventilating. And you kind of assess them and see, do they need assistance from me? Are they able to do this on their own? Once you feel comfortable, you switch over on the nasal cannula, the non-rebreather, and then you give the okay to start heading down to PACU or moving over to the stretcher, whatever you need to before you leave. With that being said, though, and again, I keep saying we'll get into this later when we do deep extubation. I can't stress this enough. So many times I see residents coming through that will wake up the patient. They'll see that first breath come through on the mask after they extubate, and then they'll just throw the oxygen mask on and start doing all these other things. And they forget to keep being vigilant, vigilant, right? Am I saying that right? Oh my goodness, I'm going to ruin this.
I would love to correct you, but I love seeing you struggle over this.
Okay. Now I'm second guessing myself.
You're saying diligent and vigilant.
Vigilant.
Yeah.
Correct. Thank you.
Yeah.
For those that don't know, like I'm a math and science guy when it comes to grammar. My goodness. Vigilant. Thank you. So you need to be vigilant with the patient after you have extubated. And so many times I see patients or students or residents that come through, they'll extubate and then they just move on. They're cleaning up their workstation, making sure their drugs are wasted, logging out, closing out their charting system to go to PACU. And the patient may be apneic for 20 seconds and they don't even realize it. And then they start to hear the drop in saturations and they have to go give a draw alert. And so you constantly have to multitask here, closing out everything, but you have to keep an eye on your patient. This is a very strenuous time for them, a very high risk time of having a laryngospasm that can occur even after you've successfully extubated and they've had a breath or two. I've had it happen before where I've had a patient completely go into a spasm even 2 minutes after they've been extubated and they were breathing totally fine for me during that time. So even if it's an awake extubation, you have to keep an eye on the patient's ventilation status.
At this point, sometimes the patient may, like Cole said, it's so important that you're listening to the patient. I always like to put my hand over the mouth too a little bit and just feel that they're actually ventilating if you're not quite sure, especially do that with peds. But sometimes here, the patient might not be breathing just perfectly, and you can, do an oral airway, you can do a bunch of different things. Sometimes it's literally just the position of the head. A lot of times if you tuck that pillow underneath their shoulders and get their head tipped back a little bit, that's all it needs. Sometimes literally turning their head from the left to the right is all you need. Just positioning the head a little bit sometimes will get you to have the patient taking nice breaths. And so something to keep in mind. Sometimes it's just as simple as how they're positioned on the bed. We move them over to the stretcher, that pillow gets all bunched up and they can, not be in a great position. So sometimes it can be that simple. Another thing I'll say is that sometimes one of my biggest pet peeves is we know the pulse ox is delayed. And so sometimes you'll move the patient over, you'll see a little bit of a DSAT, or you could have a little bit of a DSAT if the patient wasn't breathing great at the very end, or if there was a little bit of struggle there at the transition. If you place your hand over their mouth and you feel that they're ventilating very well and you have oxygen flowing, just give it some time. Sometimes I'll notice that people start moving to the next thing quickly. We're trained in anesthesia, don't do the same thing, more than once. But in this scenario, you need to let therapies work. So sometimes the patient is breathing very well. Maybe they weren't for a second, and you reposition their head, and now you can tell they're breathing very, very well. You've got oxygen there. Give it time to work, because a lot of times you'll see them moving on to the next thing, and it's like we're just doing a lot of things inefficiently when we could just let the one thing that will work, and you need to let that pulse ox kind of catch up to the patient picture. All right, so the next thing we want to talk about is how we're actually going to manage laryngospasms. Like Cole said, this doesn't have to happen immediately when you pull the tube. This is why we need to be vigilant while we are, getting out of the room and getting over to PACU. You're listening for the patient. You're listening for that kind of high squeak noise when that's the sound of air moving through closed or closing vocal cords. The first step is going to be positive pressure to the vocal cords. We've already talked about that, where you're trying to keep those basically pressed open by pushing positive pressure through there and reducing the opportunity for them to snap shut. If they are shut, what we can do is a Larson's maneuver. So that's going to be placing your fingers directly behind the jawline, pulling up, and you're going to have positive pressure there on the mask. As you're doing that, that Larson's maneuver can help break the laryngospasm. If that's not helping, I'm speaking out of both sides of my mouth, because I just said you need to let therapies work, but this is a scenario where if you're doing positive pressure, it's not working. You've done the Larson's maneuver, it's not working. You need to keep moving on and moving to the next thing, because this is critical. We've already talked about how patients can have negative pressure pulmonary edema from biting on a tube. This is a scenario that is not going to get better from just letting it ride out. When the patient has cords that are shut and those reflexes are not intact, we need to be managing this and managing it quickly. So
the reason why you move on quickly here and not the other parts Tanner was talking about is because you can see right away the result. If you don't see end tidal, which should happen breath to breath. So you should know within a breath if you have end tidal. If you don't, you need to move on. The reason you wait on the pulse ox is because you're going to be delayed 20 or 30 seconds on the pulse ox for whatever move that you make for that to change the amount of oxygen getting into the bloodstream and going to where the pulse oximeter is reading it, which is why so many times other staff in the OR, when I have a patient with a MAC procedure that drops their oxygen, they'll look at me like they're really nervous because the patient's still 60 or 70% after they've dropped, and I'm not nervous. And they're like, well, they're 60%. And I go, yes, but now they're ventilating. I see end tidal, give it 20 seconds. And then sure enough, they come back up because you can tell when somebody starts ventilating right away. So when Tanner says he's speaking out of two sides of his mouth, he is, but he really isn't, because in this case, you can see the result right away. The result is we want end tidal. If you don't have end tidal, you got to change what you're doing. Otherwise, it'll take that 20 seconds to have the oxygen come back up.
100%. So let's say we've done Larson's maneuver, positive pressure, that's not working. Move on to bolusing propofol, trying to get them back sedated, where hopefully they're going to relax and those vocal cords are going to open up. In severe cases, we've given propofol, it's still not relaxing the spasm. You need to move on to actually relaxing the patient and giving a neuromuscular blocker to get those vocal cords to relax and be able to pass air and start ventilating the patient. So typically what you'll see is when you initially have a little bit of a spasm, and you'll hear people talk about like that, it's not an all or nothing thing. They're like, oh, there was a little spasm there. It's not like it's all or nothing. Sometimes you'll be giving positive pressure, you're squeezing the bag, you can feel that you're getting a little bit of end tidal, just a tiny fog in the mask. And this is one where maybe you stick with that for a second because you are getting a little bit of air movement. And as you keep giving those breaths, it'll slowly start to relax and you'll be getting those full breaths as you work through that spasm. If it's completely shut and you're not getting anything, again, this is where you need to start moving quickly to propofol or potentially relaxing them with a neuromuscular agent. So a lot of times, if you have a patient that, didn't get them suctioned out completely and a little saliva drop down in the cords or is irritating, or if you're doing ENT procedure and there's some blood that dripped down there, there's multiple reasons why this could happen, but they don't have the reflexes fully intact where they can clear that and be breathing sufficiently on their own. So that's laryngospasm. Let's wrap this up with a couple techniques here. We've talked a little bit about deep extubation throughout this whole 2 episodes. And we also want to just touch on different types of emergence techniques. So nitrous emergence and then propofol emergence. So Cole, you want to dial in on deep extubation, and then I can jump back in on the nitrous oxide.
Yeah, totally. And I feel like you're going to have to follow up on this deep extubation because you do this more than I do. I'm more than a awake extubation guy, but let's talk about, right? You're more of a deep extubation guy.
No, that was our friends.
Okay.
If our friends are listening, that was our friends who do anesthesia wrong.
Yeah, exactly. Okay, never mind then. We'll both be talking about this. So deep extubation is something where it's very useful to have in your tool belt. Like, this is something where there are situations where it is better for the patient to do, or to at least attempt, a deep extubation than it is to wake them up. So, for example, a time that this may be better than an awake extubation would be, you don't want the patient to cough on wake up. So there might be ENT procedures around the neck where you don't want them to be coughing. There's fresh incisions and sutures there. Maybe you're doing a neuro procedure and they want to minimize blood pressure, and you don't want to wake them all the way up and have them coughing or gagging, and their blood pressure rises and spikes, and it messes up with maybe an aneurysm that they just repaired in the brain, etc. Whatever the case may be, though, there are definite situations where a deep extubation may be preferred. But even if the case shows that you should do that, it always comes back to a patient-by-patient basis. If you have a patient that was difficult to mask to begin with and a difficult intubation to begin with, I probably will not be doing a deep extubation, even if it is an ENT procedure. And there's some things that I can do to minimize how agitated the patient's going to be when I do an awake extubation. But what is a deep extubation exactly? So in this case, the goal is to get the patient back spontaneously breathing, just the same as we've described earlier, but you do not decrease the volatile agent. So again, you don't decrease the volatile agent. They're still completely anesthetized. And we actually want the patient to be over a full MAC of volatile agent once, and preferably closer to like 1.3 on their MAC. This is to completely blunt the airway reflexes. You want to minimize, again, any risk of a laryngospasm, because the last thing you want is to have them so deep under anesthesia and they still spasm, and now you're trying to mess with all of that. And so you really want to make sure that they have their airway reflexes blunted, but you can simply just remove the tube. They continue to ventilate spontaneously. You have an oral airway in, put them on a mask, and you just take them down to PACU. Take them down to PACU, and they slowly, spontaneously breathe off the anesthesia gas. So how you do this is, again, patient's fully reversed. They're strong enough from a train of force standpoint. They got 4 of 4. They're not going to be commanding, though, because they're completely asleep. And you want their pain control to be just like it would be with a normal emergence. Again, the difference is we're just doing this under a full amount of volatile agent. So this is, again, why it's so important that you assess how easy the patient was to ventilate prior. And it becomes difficult. Like, that sounds simple, but it becomes difficult when you're constantly giving breaks to people. You take over cases and rooms at the end of the day if somebody gets relieved. And now you're waking up a patient that was potentially a deep or difficult mask, and you're trying to do a deep extubation. And so this is something where you have to pass this along to your colleagues. If you are planning on doing a deep extubation, that you have to mention to them, here's how difficult the mask was, here's how difficult the airway was, etc. Once you get them extubated, though, the whole process is the exact same. It's just now you turn off the gas, you turn up your flows, you let the patient just exhale the remaining volatile agent with the tube out. But again, this is where have to be diligent. It's imperative that you monitor the patient's ventilation status. Again, you don't just do this and walk away and start doing your other things. You have to make sure that they don't go apneic, and as they go through stage 2, they don't have a laryngospasm.
I was hanging out with a buddy the other day, and he does not do any deep extubations. And he's like, I'll have students come through that say, hey, I'm going to do deep extubation on this. And he's like, literally, I'll be like he obviously knows how to manage them and all that kind of stuff. He just doesn't personally practice deep extubations. And he's like, I'm always in shock at how good they are at doing deep extubations. And he's like, I haven't practiced it. I'm not that good at it. And then I'll just be like, sure. And then it'll work beautifully. And he's like, I'm just learning. Even though I'm the preceptor, he's like, I'm learning when they come through and do this, because it's not really in his bag of tricks that he normally does. But like you said, there are times when it's very important that you would know how to do this and be able to do it effectively. All right, let's talk about nitrous oxide wake-ups. So this is something that I will do actually pretty frequently. Nitrous gets a little bit of a bad rap because, it has increased risk for nausea. Typically, that's only if you've used it for greater than 30 minutes. Also, we know that when we're pre-oxygenating somebody, really we're denitrogenating the lungs. So we're giving them 100% oxygen. And if you're giving somebody nitrous, well, you're not pre-oxygenating them before you would extubate the patient. So you need to be very vigilant. We're using that word like it's going out of style on this episode. You need to be vigilant to understand, is this an appropriate patient that could tolerate not having 100% oxygen before we extubate this patient. There's also certain procedures that there's going to be, they're going to be working in closed spaces where it's not appropriate to be using nitrous as well. So nitrous is not a uniform go-to method. You need to make sure that it makes sense for the patient, makes sense for the procedure. What's really nice about nitrous is that it has a little bit of pain control. So that's nice. It's very quick on, quick off. And so it's not really going to get you, coverage in PACU, but it does have that side profile. What's really nice about it is that it's very fast off. And so if I have a patient, let's say I'm running them just on nitrous at the very end of a procedure, sometimes I'll do this for total shoulders and they're sitting up and they have an LMA in. At the very end, the patient's blocked. They're not having any sensation from the closure, and I'll just have them on nitrous. I can have them close to a MAC or 3/4 of a MAC, not a MAC, but 3/4 of a MAC of nitrous. And it's literally less than a minute when you turn that off to when they're fully awake. CEVO is going to take much longer for that to completely come off. And so nitrous is kind of a nice bridge if you want to use that in that method to have a little bit tighter control of exactly when the patient is going to wake up. Again, not perfect in all situations, but something to use if you're wanting to maybe dial in how quickly you're able to have that patient fully awake. In the same vein, propofol wake-ups are very nice for this reason too. You can turn off your gas completely, and now you're really running it like you would an endo procedure, where you're just bolusing, 20 to 40 milligrams of propofol at a time, and you're still keeping their brain asleep, still keeping them sedated, but you know how fast propofol is on and off. And so if you have somebody that you're nervous, the gas is going to take a long time to come all the way off, then getting the gas off early and then just giving little bumps of propofol at the end is a nice way to do it. There's also some discussion that we know that it has antiemetic properties as well, but there's there's some thought processes behind that as well, that people think it helps a little bit with postoperative nausea by giving little bumps of propofol. So two little, I would call them more of like tricks to use as you're waking a patient. They're definitely not necessary. You can wake up a patient straight from SIVO, no problem. But if you're wanting to add a few things into your wake up routine to maybe tighten up your window of when you know exactly when they're going to wake up, and you're not having to guess how long it'll take for that last little bit of SIVO to come off, then you can use those two techniques to kind of help with that.
Yeah, I think what I love about both of these techniques is it helps your time management of how do you wake up the patient in a quick fashion once the surgery is done, but not too early that they start to move or compensate the end of the surgery itself. And the reason being is, again, the SIVO emergence just takes the longest. It's the most variable, again, depending on how long the procedure went, et cetera. And if you could just turn that off or turn it all the way down and then just put on nitrous and propofol, now what your timeline is to wake up that patient in a much more finite time period than you would if you were just emerging from SIVO. And so it makes the timing of your wake-ups that much more predictable, which is why it's very, very nice. And again, nitrous oxide has that secondary gas effect, so it will also help pull the SIVO out as well in your remaining SIVO when you do turn off the nitrous at the end of the case. So with this being said, this by no means is a complete comprehensive emergence talk. I know we spent 2 episodes talking about this. And again, there are so many ways to do this, so many different strategies to use, so many different combinations of them, that you're going to format your own way of doing this. You're going to figure out, okay, here's all the different things in my tool belt that I can use. And you're going to pick the right situation to use the right tool that you have to make sure that patient gets to PACU in the most comfortable, stable, predictable way possible. And again, this is something that takes several years to master. You have to go through it. You have to try different ways. And that's why working with different preceptors is so important. And also when you're a CRNA, going and giving breaks is so important, because you don't get the tunnel vision of doing it the same way every time. And you can learn different tricks of the trade, so to speak, to give yourself and the patient the best opportunity to get in the PACU in that stable position.
All right, that wraps up our episodes on Emergence. I got a little visitor here at the end of this episode. It's my daughter, Scotty. I want to see if you want to say anything in the microphone to close us out. You can't see it, but she's gnawing on the microphone. So that'll have to do. But yeah, hopefully this is helpful for you guys as you are doing the critical step of emerging a patient from anesthesia. Don't beat yourself up about it. It is difficult to master this skill, but hopefully these episodes will be one step closer to just getting some more ideas and understanding around this critical time in the anesthetic.